Good afternoon, and thank you for joining us. I'm Dr. Bob Hopkins, Medical Director for the National Foundation for Infectious Diseases, or NFID. I'm also a practicing physician caring for both children and adults. Welcome to the final session in our NFID Respiratory Season News Briefing Series. For more than 50 years, NFID has educated and engaged the public, communities, and healthcare professionals about preventing and treating infectious diseases across all ages. These briefings are an extension of that mission, providing timely updates and expert insights during a respiratory season that is anything but typical. Today, we're facing overlapping threats from flu, COVID-19, RSV, and pneumococcal disease against a backdrop of declining vaccination rates and growing uncertainty. NFID recently surveyed U.S. adults, and the results highlight the challenge. Only 45% of respondents said they've received at least one respiratory vaccine since September 2025. And nearly half, or 44% of U.S. adults, say current guidance on which vaccines to get is unclear. These gaps matter because they translate into real risk for families and strain on our healthcare system. The NFID survey also revealed why vaccination rates are low. Among adults who've not received a flu vaccine this respiratory season, 16% expressed safety concerns about vaccine side effects. Similar patterns emerged for COVID-19, with 20% citing worries about side effects. For both flu and COVID-19, 12% of unvaccinated adults stated that vaccines do not work very well, and 12% are concerned about getting sick from vaccines. 25% of respondents agreed that they could not access COVID-19 vaccines in their area. This number was higher among Black and Hispanic respondents at 32 and 34% respectively. We also see generational divides in trust. While 44% of adults trust their doctor, nurse, or pharmacist most for vaccine information, among Gen Z, defined as those 18 to 28 years old, social media ranks second, a concerning trend given the volume of conflicting information online, including persistent questions about vaccine safety and unfounded claims about the long-disproved theory linking autism to vaccines. These insights underscore the complexity of this season and the urgency of providing people with clear, evidence-based information to help inform their decisions to get vaccinated. Today's discussion will provide a pulse check on the current respiratory season, discussing both short-term and long-term impacts on public health, and bringing science-based information and hope to the forefront. It's on us to lead by example and to elevate the health and safety of families and communities across the United States. To help us understand the current seasonal vaccination rates, we're pleased to have Nandini Selvam from IQVIA here to share insights drawn from comprehensive U.S. insurance claims and retail pharmacy data, giving us a real-time view of vaccine uptake across the country. Nandini, you have the floor.
Excellent. Thank you, Bob. Good afternoon, everyone. So if we can shift to the slides real quick. So here's an overview of the vaccination data from IQVIA's National Prescription Audit, which shows the number of vaccinations administered to adults in retail channels. When I talk about retail channels, what I'm talking about are pharmacies, mail order, and long-term care settings. So this data does not actually reflect on vaccinations provided in other settings, such as doctors' offices, hospitals, clinics, or other non-retail locations. Since we're evaluating respiratory vaccines, thinking of the influenza season as a reference, all of the vaccines have been categorized by the same seasonality, even though pneumococcal and RSV vaccinations are not necessarily either yearly or seasonal. As you can see, we've evaluated data from the beginning of August through November 21st of this year and compared it to the same time frame with respect to the volume of vaccines administered in the same locations last year. There were decreases in all but pneumococcal vaccines, but I'll go through a more detailed view of those in the upcoming slides. Next slide, please. Yeah, thank you. So in the way to read this is you can see from the curves on the right, which signify the current season versus the gray box that shows the prior season. So this is just for visual. There's an overall decrease in COVID vaccines in adults by about a third. And you'll see that this is across all age groups, including the older adults as well. Next slide, please. For flu, we see about a 6% drop in retail channels. We'll have to monitor this throughout the season to see what's happening in other channels as well as what's happening in the retail outlets as well, as the season progresses. But if you look at the curves from where we saw it in August of 2024 versus August of 2025, and then the peaks, you can see that there is a decline. How much is declining overall? We'll just have to see as we monitor. Next slide, please. In terms of pneumococcal, there was nearly a third increase in the pneumococcal conjugate vaccines administered. It's important to note that the guidelines for this vaccine did change. So it now recommends vaccination for those 50 years and older versus 65 plus previously. Additionally, pneumococcal is not a yearly vaccine. At this point, it is recommended for a single administration, although there are some nuances based on which type you received initially. Next slide, please. So this is my last slide, and it's about RSV. And again, we see a decline in RSV vaccinations also. Again, this is not a yearly vaccine. Current recommendations indicate a single administration of the vaccine for those 75 plus and among high-risk adults that are 50 to 74 years old. Some of the activity in the younger adults could also be from vaccination during pregnancy. So if an adult does not need to be vaccinated, current guidelines recommend receiving the vaccine in the late summer or early fall ahead of RSV season. But these are all the vaccines that we're currently tracking in this particular view. So Bob, over to you.
Thank you, Nandini, for sharing these important insights. These numbers aren't just statistics. They represent real gaps in protection that could translate into more illness, more hospitalizations, and loss of lives. That's why today's conversation matters. Now let's turn to our expert panel to discuss what these trends mean for families, for communities, for employers, and for the U.S. healthcare system, and what can be done to change the trajectory. I'd like to ask each of our panelists to briefly introduce themselves. I want to start with Dr. Rochelle Walensky, who served as Directors for Disease Control and Prevention from 2021 to 2023. Rochelle?
Thank you so much, Bob. Rochelle Walensky, as Bob noted, I served as CDC director from 2021 through May of 2023. I'm a professor of medicine at Harvard Medical School and in the Division of Infectious Diseases at Massachusetts General Hospital. And for the past several months now have been serving as the Chief Medical Advisor for the Vaccine Integrity Project.
Thank you, Rochelle. And now Dr. Peter Hotez of Texas Children's Hospital Center for Vaccine Development and the National School of Tropical Medicine at Baylor College of Medicine.
Yeah,
Peter?
Thanks so much. I'm Peter Hotez. I'm an MD, PhD pediatrician scientist, a laboratory investigator that develops new vaccines. We developed a low-cost COVID vaccine technology that reached 100 million people in India and Indonesia as Corbevax and Indovac. And I have an interest in parasitic disease vaccines, including a new hookworm anemia vaccine. And then have this unplanned part of my career, which is meeting my wife, Anne. We've been married almost 40 years and have 4 adult kids, including Rachel, who has autism and intellectual disabilities. And a few years back, I wrote a book called Vaccines Did Not Cause Rachel's Autism, which wound up making me a target for anti-vaccine activists. So by default, I became an expert not only in the vaccine science, but the vaccine anti-science. And I write and speak about that as well.
Thank you, Peter. And finally, Dr. Tom Frieden, also a former CDC director who served from 2009 to 2017. Tom?
Thanks very much. I was, as you say, CDC director for nearly 8 years. I also am currently president and CEO of Resolve to Save Lives, and I've just published a book, The Formula for Better Health, How to Save Millions of Lives, including your own.
I want to thank you all. Let's dive into the discussion. Peter, if vaccination rates continue to lag, what are the immediate and long-term consequences for individual families, communities, and the broader U.S. healthcare system this winter?
Well, unfortunately, it's happening on multiple fronts. Even though we're mostly talking about respiratory viruses, I'll just mention the fact that we've seen a sharp resurgence in measles this year. I had a measles epidemic lasting 8 months. Began in my state of Texas, landed 100 kids in the hospital, and 2 needless deaths among otherwise well school-age kids whose parents decided not to vaccinate them. And now it's continuing in Western states, and they may be linked, so we risk losing our measles elimination status. We've seen a 6-fold rise in pertussis cases, whooping cough, from 2023 to 2024. It's looking like 2025 could even be worse, so I'm expecting pertussis to return, and from there on, all bets are off. And then with the respiratory virus infections, if we have, the numbers are just starting to pick up now for this winter season for both COVID and influenza. And if we don't vaccinate, we're going to see again unnecessary hospitalizations and deaths. So there's a lot at stake, and this is why our conversation today is so important.
Thank you. Tom, what are the biggest barriers preventing widespread vaccination, and what bold strategies could help overcome them to protect more people this respiratory season?
It's really about information, access, and affordability. All of those things need to get addressed. With information, we need clear, simple messages. And to be clear, flu and COVID can be deadly. The flu and COVID vaccines are not as effective as we would wish, and this year's flu vaccine may not be as well matched as it is in some years. But even with all that, the flu and COVID vaccines are the best way to protect yourself against flu and COVID. I get them every year, my family gets them every year, and I recommend them. They're particularly important for kids and the elderly and people with underlying health conditions. So information, access, and affordability. That's the information part of that. For access, it's great that you can get vaccines in your local pharmacy. Recent activities in the US government have made that a little more challenging, in some states in particular, but most states have now addressed that, so that if you want to get a vaccine, you can. No one is telling you to get forced to get vaccinated. You decide. What I decide for me and for my family and those who ask my medical advice is that flu and COVID vaccinations are the best way to protect yourself from flu and COVID each year. And in terms of affordability, currently, most people can get vaccines free. However, that needs to be maintained, because you decide it becomes much more difficult if that decision is costly for you economically. And what we know from the uptake of essential healthcare is that any co-payments decrease use. And this isn't just about individual decisions, though every vaccine is given only after informed consent. This is also about our protection as a community. We know that the more people who are vaccinated, the lower the risk to people who, although vaccinated, may not have an immune system that responds well to that because of immunosuppression or other reasons. So flu and COVID remain deadly, and flu and COVID vaccinations remain the single best way to protect ourselves from these infections.
Rochelle, the Advisory Committee on Immunization Practices is meeting this week amid significant changes in vaccine oversight, including the Food and Drug Administration's push for new standards on vaccine testing. What should the public and healthcare professionals watch for in these meetings? And how might those decisions shape the future of routine immunizations and our ability to respond quickly during respiratory virus season?
Right. So I think another change that you didn't mention, but is also true, is that there's a whole new host of members of the ACIP, as the prior members that generally roll off every 4 years have been entirely replaced. So as I look at this meeting, first of all, I should articulate that it is the CDC's job and the ACIP's job to intermittently look at current vaccination policies and to understand those policies in the context of new data and new epidemiologic trends. That is their responsibility, and I applaud those efforts. So I don't mean to imply that we shouldn't be doing that. What I do want to have people recognize is who is doing the speaking, who is doing the presenting, and the kind of science that is being represented. It became clear to us at the Vaccine Integrity Project, for example, in the summer and fall, that the ACIP was not actually doing what it usually does every fall or every summer, and that is evaluate the newest published data on the safety and effectiveness of the respiratory virus vaccines. So we at the Vaccine Integrity Project took on that task, and we reviewed this past summer over 17,000 papers, 17,000 abstracts we looked at. Over 500 papers were abstracted. All of this data is available on the Vaccine Integrity Project website, including a hyperlink to every single paper we reviewed. And the summation of that review is now published in the New England Journal of Medicine. So people can look at the science, even though that was actually not done at the ACIP meeting. So I am looking for scientists presenting scientific published data or early data that has not yet been published, but in a scientific form. And my understanding, based on reporting that I've been hearing, is that the experts who know and understand those data, who are the reliable scientists around those data, have not been invited to that table. So I will be looking specifically for that.
Yeah, I would just add to that. Remember, this new version of ACIP has been stacked with anti-vaccine activists who either are incurious and have no interest in the science or are unable to understand the science. And therefore, what goes on at that ACIP meeting, quite honestly, is of no value to the public. It is purely a platform to promote pseudoscience and Maha pseudoscience, and that's what's very important to understand. And it's a very dark chapter in the history of American biomedical science, but that is the reality. And so one has to be very careful when you watch that ACIP proceedings and remember that that there's going to be a lot of fact-free information presented and interpreted accordingly.
Tom, are we prepared for the possibility of a severe respiratory season? And what lessons from past pandemics are shaping the healthcare system response strategies now?
Well, I think unfortunately we are not as prepared as we should be or could be. We know that preparedness requires trust. And what we've seen, despite the fact that the stated goals of this administration are to restore trust in public health and CDC because of a variety of factors, including statements that are non-factual and allegations that are incorrect about past membership in the ACIP, we're seeing historic low levels of trust in public health. And that is potentially deadly when it comes to responding to emergencies. Beyond that, we're seeing the undermining of public health departments and the ability of public health to act. Furthermore, we're coming into this in a healthcare system that has continued to under-address and insufficiently support primary health care, family doctors. And family doctors are the first line of defense. They're the ones who will detect and diagnose a problem when it first emerges. They're the most trusted source of information, a local clinician, whether it's a nurse practitioner or a physician, who patients can relate to, trust, listen to, choose for themselves. And we're also undermining the public health capacity to respond with lower investments in everything from detecting foodborne outbreaks to responding rapidly to health threats. What you've seen, for example, this year, for the first time in history, is states requesting assistance of the CDC and CDC being unable to respond. That has never happened to my knowledge, and I've discussed with other CDC directors for decades. In fact, when I joined CDC as an Epidemic Intelligence Service officer in 1990, I was told in no uncertain terms that if a state or other area requests assistance with what's called an epi-aid or epidemiologic assistance with an outbreak, You will be on a plane by the time the sun sets, or another EIS officer will be. Now, the response has been, we'll get back to you, or we're unable to respond. That is really unsafe. That means that we as Americans are less safe. Investment in our public health infrastructure is just as important as investment in our military defenses, despite the fact that we spend at least 300 times more on our military defenses, and no war in history has killed 1 million Americans.
Rochelle, the FDA's linked memo and recent headlines have raised questions about the childhood vaccination schedule and COVID-19 vaccine safety, despite strong evidence to the contrary. As ACIP reviews the childhood immunization schedule, what's your message to families concerned by conflicting narratives about vaccine safety and the necessity of vaccines?
Right, Bob. So I don't do science by memo. We do science by reviewing the data in the literature. We did not see the data in the literature reviewed at the last ACIP meeting with regard to the safety of COVID vaccines. A comprehensive updated review is available at the Vaccine Integrity Project website and in the New England Journal of Medicine paper that was peer reviewed. Those data demonstrate and did again find the finding of myocarditis among young men that was relatively rare, and rarer still when the spacing happened with annual booster doses. So the findings of that review demonstrate the ongoing safety of the COVID-19 vaccines. What I will say, though, is if you can't do science by memo, you can do conflicting narratives by memo, and you can confuse by memo and undermine vaccines by memo. And that is the intent, I believe, of this memo. I think we and the medical societies, as healthcare professionals, hospitals, your personal healthcare provider and doctor have actually been singing with a continuous unified voice. The thing that has been divergent, very sadly, I think over the last several months has been not the medical societies and your providers, but in fact the US government. And that I think is really an intentional intent to confuse and undermine.
Peter, there have been a lot of interest in the risks and benefits of mRNA vaccines recently. And one new study found that cancer patients who received an mRNA COVID vaccine within 100 days of starting immunotherapy were twice as likely to be alive 3 years after treatment as those who never received a vaccine. What would you say to people who are concerned about mRNA vaccines?
Well, what I would say is in the United States, we've administered almost 1 billion doses of mRNA vaccines. I mean, I believe it's over 900 million doses, and it's had an extraordinary record not only of safety, but of effectiveness. Estimates from my colleague Alison Galvani at Yale and Megan Fitzpatrick estimate that COVID vaccines during the pandemic saved 3.2 million American lives and averted 18 million hospitalizations. So if it wasn't for COVID vaccines, instead of 1.2 million Americans dying from COVID, it would have been 4.4 million, which would have been catastrophic. And, the technology is still relatively new, but given the fact that we've had this unprecedented experience, we've learned a lot about mRNA vaccines, and the potential is just the beginning. So even though our COVID vaccine was an older technology, recombinant protein vaccine, we've also now taken on the mRNA technology and finding that it has amazing opportunities, for instance, for cancer vaccines. And that may be one of the few technologies that could really work for therapeutic cancer immunizations. And the reason is simple. You can move very fast to make a piece of mRNA so that if you know the new antigens being expressed by a patient's tumor, you can move in very quickly and make that vaccine, whereas older technologies take a lot more time. And this means new vaccines for cancer, new vaccines for autoimmune disease, and guess what? New vaccines for things like influenza as well. If our country were to avail itself of that, because you can get with a shorter time frame. If you know the influenza variants that are sequencing, you can move pretty quickly to make that mRNA, and it could be one of our best hopes for new pandemic threats. And this, this is another concern I have with the MAHA movement and what's doing in the U.S. government. There was a decision by BARDA, the Biomedical Advanced Research Development Authority, to cancel two major mRNA vaccine contracts for, I believe, these were over $1 billion in two contracts for influenza and other illnesses. And what do they choose to use instead? An older technology, which would require a lot of adjuvants like TLR agonists that will increase the likelihood of Guillain-Barré syndrome, just because they have this pseudoscience idea that it's closer to stimulating natural immunity. So the mRNA technology, all vaccine technologies have strengths and weaknesses, and that's for certain. But to completely take mRNA vaccines off the table, I think is very reckless, and both for our pandemic preparedness and for the next generation of therapeutic vaccines for cancer and other chronic illnesses.
If I can just add to that, there is a lot of concern about mRNA vaccines. I'm not entirely sure why, perhaps the name, but it's very important to put this in the context of what's been happening with vaccine science over the past couple of decades. What we've seen is a series of advances in the what are called conjugation of vaccines. So, for example, when I was training, we commonly saw kids and seniors with very serious Haemophilus infections. The vaccine is a great vaccine, which has basically abolished those infections. So we have better adjuvants. We have more focused vaccines. So we are protecting people against more diseases with fewer antigens. That's what's happened. And mRNA is one. It's a very exciting, but it's one of several advances in vaccine technology.
Yeah, I mean, we're at the point now, Bob, where from almost any new, certainly for virus pathogen, some of the other pathogens are more complicated, like parasites, but certainly for a virus pathogen and most bacterial pathogen, we can move pretty quickly as long as we avail ourselves the full range of technologies available to make a vaccine. The problem is, and we saw this with Ebola, even though that wasn't an RNA vaccine, it was a vesicular stomatitis virus vaccine that stabilized the African continent during the 2019 Ebola epidemic in the Democratic Republic of Congo. So we have two examples where a brand new pathogen arises, Ebola in 2019, then COVID-19 following that, to address pandemic threats. But if we squash it because of ideology, then we're in a situation where our technical ability to make the vaccines is no longer the rate limiting step. It's trying to understand the political and economic landscape behind it.
And maybe just to close that loop with you, Peter, the single most important issue related to how well a country will do, the globe will do in a pandemic outbreak is how quickly we are able to have a vaccine. And the ability for us to have that vaccine quickly is right now best with mRNA, both safely and quickly. And I think that actually makes it very exciting and very promising and very difficult in this moment, given where the politics are.
I mean, our biggest issue, our biggest risk right now, vulnerability as a country for the United States of America, is the collapse of our national biosecurity. We know that regular respiratory virus pandemic threats are going to be a new reality, right? We've seen that with H5N1. We've seen it with the next coronavirus. We've already had SARS-1 in 2002, SARS-2 in 2019. We'll have a third SARS-CoV-like virus coming down the line. Now that's a huge risk for us. Where I am in Texas and the Gulf Coast, we're being buffeted by an array of vector-borne illnesses, including dengue, which is expanding out of the Amazon rainforest in Brazil. We're seeing tick-borne illnesses. There's even risk of yellow fever. That's going to be a major threat now for Texas and the Gulf Coast in the foreseeable future. Third, I don't have security clearance, so I don't have the inside baseball on this, but, looking at the reports from the Washington Post and elsewhere, it's clear that foreign actors like Putin are accelerating their bioweapons capability. And now we have a vulnerability where, for ideological reasons, we're going to stop all efforts to develop and stockpile vaccines, which are our only major bulwark against it. And that message really needs to get out, which the press really hasn't done in terms of the total collapse of our nation's biosecurity.
Rochelle, according to the NFID survey, only 13% of U.S. adults trust the CDC most for accurate information on vaccines. Why do you think the public's trust in CDC is eroding, and what are the implications of that erosion?
Well, maybe I'll just start by saying that's been a plummet over the last several weeks, months. I mean, when I saw that number, my jaw dropped, disturbingly. I will say when I was at CDC, I'm going to guess when Tom was at CDC, that website was sacrosanct with regard to the data that got put on it. It was vetted heavily by subject matter experts for both clarity and accuracy, and updated routinely when new data became available. And so it's been really disturbing to see what I'll call a hijacking of that website by people who are posting information that is not cleared, or I would say posting things that is not cleared by subject matter experts within the CDC. So that, I think, is part of the issue. I think the firing of the ACIP members, there have been numerous times over the last several weeks and months that we can see completely inaccurate or irresponsible things that have been put under the CDC banner that I will say, especially since I know many of the amazing civil servants who are scientists continue to work at the CDC who have not approved those postings. So I think it's been an intentional undermining again of the trust of the agency. I will say, though, that there are still people who are there who are working hard to protect America's health, safety, and security every single day. Their voices are oftentimes not heard. Their work is oftentimes not heard, but they are continuing to do that work for the American people, and that puts the agency in a very tough place. What I will say, though, in the context of trust is we do know, and I really want to go back to, especially since this is about respiratory virus season, I want to go back to a comment Tom made earlier. We do know that we are heading into a respiratory virus season. We are potentially thinking about a bad flu season. People are anticipating a potential bad flu season. Last year, we had more pediatric deaths from influenza than we've had in the last 15 years. And among the most important things that you can do to protect yourself and your loved ones is to get a flu vaccine and a COVID vaccine and an RSV vaccine if you're eligible.
Peter, concerns about side effects and the efficacy of vaccines emerged as top reasons for skipping those vaccines, according to the NFID survey. How do we address those concerns without losing momentum on prevention?
Yeah, I think, being able to convey the benefits versus risks of vaccines is really important. And unfortunately, what the anti-vaccine playbook is all about is to exaggerate the very rare side effects and downplay the severity of the vaccine. So we saw this during our measles epidemic, right, where you had the Health and Human Services Secretary say, the MMR vaccine is a leaky vaccine. It's not. You had, saying that the MMR vaccine, the immunity declines 4% per year. It's nonsense. If anything, it's closer to 0.04% per year, or that it's contaminated with aborted fetal remnants, all nonsense. And so I think, finding a way to counter that, I think, is really critical. One of the things that I did back in 2020, which was somewhat successful, I think, is I worked with the New York Times and their graphics person, Bill Marsh, where what we did was we built these boxes where on the box on the left, and the pictures were 1,000 words in this case, but a box on the left was, what if 10,000 kids got measles? And the box on the right is, what happens if 10,000 kids got the measles MMR vaccine? So the box on the left, where the kids getting measles are very large boxes inside because of the high rates of, if you're not vaccinated, of getting measles, pneumonia, measles gastroenteritis, neurological issues like deafness, and even measles deaths, and significant size boxes. The box on the right, where it had the vaccine, were these tiny, tiny, tiny little pinpricks that you really couldn't even see, but you had to draw arrows to point to the extremely rare side effects of thrombocytopenia and an allergic reaction. And I think that kind of information, that approach could be extremely helpful. For something like the Vaccine Integrity Project, we should be doing that for all vaccines, because it's a picture's, as I say, picture's worth 1,000 words, and it really conveys risk versus benefits in a very clear-cut way, which would be helpful not only for the parents, but even for the pediatricians and the internists and the OBs administering vaccines, especially. One last point I want to make for pregnant women. Anyone who has worked in an intensive care unit knows the horror of seeing pregnant women in ICUs because of COVID, and before that, pregnant women with influenza. Pregnant women do not do well with viral respiratory infections, and some of the highest mortality out there. And vaccines have been so life-saving for pregnant women, and emphasizing that, I think, is going to be really critically important.
Tom's survey results show younger adults tend to trust social media for accurate information about vaccines. What's the path forward to help ensure reliable information in these spaces?
I think we need to go where people are. So we in public health need to speak effectively. We need to collaborate with influencers who are prominent in social media. It's possible to promote reliable information. We need to listen and hear what people are hearing, see what people are seeing, identify the best messages and the best messengers. This is really important, that we understand what's happening in these media channels, that we build trust and societal resilience, and that we use strategies that we assess and optimize using clear language, responding with compassion. I think we really need to separate, on the one hand, to be blunt, politicians and lawyers who are weaponizing this information from many people who are legitimately concerned about how they get valid health information, who's making decisions, whether their food, water, air, medicines, or vaccines are contaminated, and respect the concerns that people have, listen to them, and identify with clarity how to communicate without losing nuance. Because science does have nuance. As an example, yes, the flu vaccine is probably not a great match this year. We won't know that for sure for about a year. But what we're seeing is reports from Europe and other places of more severe disease with new strains of flu that are not optimally matched to this year's flu vaccine. That's a complicated sentence, right? So, but the bottom line is still, the most reliable way to protect yourself from influenza is to get a flu shot every year. And so
Bob,
I think we need to learn to speak, and we need to collaborate with those who are effective messengers, looking at all of the different groups. There's not one public out there. There are many publics. And we in healthcare and we in public health need to speak effectively to each of them. We also need to collaborate with the healthcare professionals so that we are making clear, with clear recommendations and clear guidance, what people can do to protect themselves and their family.
Bob, just a shout out to you and NFID. This is why, when you invited me, and I'm sure Rochelle and Tom feel the same way, we jumped at the opportunity because we recognize, we don't get the opportunities we need to really get good, positive, and scientifically sound, evidence-based messages out there. So thank you for doing this, because it's vitally important. I would just add also, I think one of the issues that I'm seeing, I give a number of pediatric grand rounds across the country, every year. And one of the things that I'm hearing from the pediatricians is, parents are now, downloading garbage on the internet, and they're coming into the pediatrician's office made to feel like they're not keeping up with the literature. Well, they are keeping up with the literature. They're just not keeping up with the fake stuff. So I think one of the things that we need, and maybe this would be through the Vaccine Integrity Project or through NFID or a collaboration, would be, look at the 50 or 60 most common anti-vaccine tropes, nonsense like mRNA vaccines are causing turbo cancers. And, these are easily debunked, but, pediatricians and internists and OBs are busy and they don't have time to go scouring the internet to go look for the reasons why the parents are coming in or the patients coming in and what they're saying is not true. So having that available, I think, could be an important public service for the primary healthcare providers.
Great. I want to thank all of you for your comments. Before we move to the Q&A, we want to share a powerful reminder of why vaccination matters. This short video features Dan McFadden, who survived life-threatening pneumonia, speaking about the importance of vaccination for people with chronic health conditions.
Hi, my name is Dan McFadden. I would like to take a couple of minutes of your time to explain why it is important to be vaccinated for infectious diseases. 7 years ago, I contracted a rare autoimmune disorder called neurosarcoidosis. That disease uses your immune system to attack the brain and your central nervous system. In my case, it attacked my optic nerve and lost all vision in my right eye. Treatment involved a series of drugs that suppressed my immune system. That left me very susceptible to all sorts of infections. As a result, I'm a big fan of vaccines. I keep up to date on all my shots. But in 2021, I contracted pneumonia. I thought I had the flu, but I kept getting sicker and sicker and sicker, and eventually ended up in the ICU on a ventilator, completely unconscious. I was lucky. My doctors were able to beat back the infection. They saved my life. But my journey wasn't over. When I got home, I had to learn how to walk again, and it was several months before I could get back to work and live a semblance of a normal life. Now, I was vaccinated for pneumonia, but apparently not the strain that I caught. However, it is very likely that the vaccine I did receive kept me from being even sicker than I was. Vaccines work best when 95% or more of the population gets them. And that's what concerns me today. With the rate of vaccination declining in this country, it makes it easier and easier for the spread of infectious diseases. And those diseases can kill. If you have concerns about a vaccine, please contact your doctor. Learn the facts before you make a decision. Vaccines save lives. Please consider getting a vaccine. If you don't do it for yourself, do it for your family, your friends, and your community. You may save a life. Thank you.
Thanks to Dan for sharing his story and reminding us that behind every statistic is a real person and a family whose lives can be changed by vaccination. And now we'll take questions from the media about flu, COVID-19, RSV, and pneumococcal disease. Please feel free to continue asking questions using the Q&A function, identifying yourself and your organization. We'll get to as many questions as we can, and we'll follow up after the briefing as needed. So the first question we have is from Liz Zabo. She states in his memo, Vinay Prasad suggested that he wants to see randomized controlled trials for all vaccines, including ones for pregnant women and maybe seasonal flu as well as pneumococcal vaccine updates. How will this affect access to vaccines for people who want them? And will people still be able to get flu shots? If not, how would that affect our community morbidity and mortality? Peter, would you like to start with that one?
Well, I think one of the things that one of the anti-vaccine tropes that's out there is to claim that vaccines are not tested through placebo-controlled clinical trials. And if you bother to actually look and do a National Library of Medicine PubMed search, in fact, most vaccines were tested through placebo-controlled trials. I think, in this case, one of the issues is what do you do when it's the same technology and against the similar pathogen, but a vaccine is being updated in order to reflect the new virus sequences. And if he's saying that now requires a brand new placebo-controlled trial, well, as SpongeBob would say, well, good luck with that, because it would take months to years in order to repeat that, and which would basically make the vaccine no longer useful. And so I think this is where certainly I diverge with a lot of the statements coming out of the FDA and CDC, is when you're updating a vaccine, I think it's absurd to require a brand new placebo-controlled trial. They're very expensive, and then who's going to pay for it? If the government's not going to pay for it, it's unlikely the companies will. And then it's the feasibility in terms, I mean, as it is, if you look at the carefully orchestrated dance that goes into updating an influenza vaccine, getting the sequences, getting the sequences, seeing what's in the Southern Hemisphere, working rapidly with the companies in order to grow up the viruses, either in eggs or cell lines. It's incredible that we do as good a job as we do. If now, on top of that, you're going to demand a placebo-controlled trial, then basically it's lights out.
Can I add a couple things to that? I totally agree with what Peter said. Several things. One is, and by the time you have the data, it's outdated, right? So by the time you have a respiratory virus season where you've matched that, you've done that placebo-controlled trial, it's the next respiratory virus season. So you are always chasing your tail and never have an RCT that will be up to date for your season. The second is it ethical? If you ask me to be in a placebo-controlled trial of flu vaccine versus no flu vaccine, I would say I want the flu vaccine. I'm not at equipoise in there. I would want the flu vaccine. And then thirdly, this is all an interesting conversation when it comes to respiratory viruses. But what if we are talking about relatively rare infections like measles, for example? Sure, we've had more cases of measles now this year than in decades before, but we certainly don't have enough to populate an RCT. And they're rare enough events that it would be infeasible to actually conduct that kind of study. So for all of those reasons, that is yet another talking point that implies that we won't have access to the vaccines that we need to protect ourselves.
So next question is from Meg Wintergerter from the Denver Post. Last year, I heard a lot of concern about agriculture workers getting a seasonal bird flu co-infection, being a risk for bird flu adapting to people. Do we have a good picture about what's happening with bird flu now and how concerned we should be heading into flu season? Some other countries have reported more severe flu seasons than usual. And the second part, do we have a sense of how much of that is due to low vaccination rates, H3N2 variant, or other factors? Tom, would you like to start with that, and then we'll ask others if that needed.
Sure. There are a few questions bound up in that. I think the one thing that's essential to keep in mind about influenza is that the only thing predictable about influenza is that it's unpredictable. We do know that the bird flu spreading widely around the world has resulted in the very substantial impacts on the agricultural economy, with hundreds of millions of birds culled in order to protect the other birds and the viability of those farms. So I think there are a lot of things that are important to improve the safety of farm workers. That includes better biosecurity there. That includes more work to reduce density of the birds there, personal protective equipment, tracking or surveillance. The concern that there could be a recombination of human influenza with the bird influenza is a theoretical risk, and for that reason, there's even more reason to consider agricultural workers getting the influenza vaccination, though the evidence that will help is limited at best. There are some countries that are vaccinating both farm workers and farm animals against this strain of influenza. That's a more complicated issue and probably not of widespread relevance. On the issue of severity, what we do see is that initial reports suggest that this may be a more severe flu season. It has been in other parts of the world. And as I mentioned earlier, that the match with this year's vaccine may not be optimal. Big picture, generally we see somewhere between 30 and 60% efficacy of the flu vaccine against serious illness. That's nowhere near as powerful as some other vaccines, which are well north of 90% efficacy, but it's a lot better than nothing, and it's better than anything else you can do to protect yourself against flu. Sometimes it's lower than 30, sometimes it's a bit over 60, but it's still the best thing we can do to get vaccinated. And another reason we really need strong global systems to track the spread of influenza around the world. You know, we are all connected in some ways by the water we drink, the food we eat, the air we breathe, and we're also connected by the flu strains we get. It is a remarkable global collaboration that has gone on for decades, that countries all over the world pool their knowledge so that we understand which flu strains are spreading in parts of the world where the flu is likely to come to us next. That's a public good. That's a collaboration. That's an example of global health and public health being a win-win. When other countries have better tracking systems and better systems to fight infections, we're safer. We're going to be healthier. And that's one reason why investment in global health is not just the right thing to do, the good thing to do, but also the best thing to do to keep ourselves safe.
But Bob, before we went live on this webcast, we were chatting, and I brought up the impact of influenza and COVID on heart health, and I think that's a message that has not gotten out. That first of all, the COVID virus, we call it a respiratory virus. In my view, it's a cardiovascular virus. It's a thromboembolic virus that causes clots to form in your coronary arteries and your cerebral vasculature. It's a leading cause of heart attacks and strokes. And so getting the COVID vaccine is probably one of the best ways to protect your heart health. That message has really not gotten out. The second is same with influenza. The uptick in heart attacks after a case of influenza is extraordinary. I was reading a story about the lead singer and bassist for the band Rush, Geddy Lee, and he talks about his father dying suddenly while recuperating from influenza. Most likely that was from the heart attack from influenza. So that's why you need to get vaccinated. It's not only your respiratory viruses, but it's the best way to protect your heart health. And that message, I think, is really critically important.
Very important messages. Rochelle, let you start with this question from Carl Hilley from the Baltimore Sun. How does America recover from the loss of confidence in our public health institutions?
Wow, we have a lot of work to do. Maybe I'll just start by saying I think the American public doesn't recognize all the ways they still trust public health. So if people brush their teeth with the tap water today, they are trusting public health. And we have to remind people all of the things that public health does for them that they are probably not recognizing every single day. Now, that is not going to be a winning strategy to regain trust, but I do want to just sort of comment that all trust is not lost. There are still many, many ways that we are using our public health systems, that we rely on our public health systems. That said, I think it's going to be very difficult to regain the trust of public health where there's a group with a megaphone that is actively trying to undermine it by posting things on federal websites, federal public health websites that are not vetted by subject matter experts, that are not accurate, that are not scientifically based. I think Tom highlighted many of the ways that we need to do outreach with regard to giving people the information that they need so that they can be the voice of the science. Even if we are not the ones that someone might trust, how is that we can empower people with the information that they need so that they can be the influencer, the Instagram followed person in health and public health. I will also say that I don't think the public health establishment can do this alone. I think this is going to take a societal approach to try and counter and tackle mis and disinformation. Among the things that we've been doing at the Vaccine Integrity Project is to try and what I call pre-bunk, to anticipate what bad information might be released and to counter it ahead of time with the information that is true and accurate, scientific-based information and evidence. So if we can anticipate what might be discussed at a given meeting, what might be posted, can we sort of empower people with the proper information, complete information, and also the uncertainties of that information. We have to be very honest about what those uncertainties are, so that we can give people that information ahead of time, as Tom actually noted, as Peter both noted, so that they have that information ahead of time, before the mis and disinformation is released.
It's
If I
really
can just
important to remember that I'm sorry, Tom, just make one quick point. There's a lot of gaslighting going on by the heads of the agencies right now, including the DHHS secretary. How many times have we heard now we're going to restore gold standard science to the FDA or to NIH or to CDC? Well, those agencies have always practiced gold standard science. In fact, they've been international role models for practicing gold standard science. So this is what they're really saying is they now want to promote a pseudoscience agenda, and I call it gaslighting. That they're trying to mess with your head and make it sound like now they're saviors for restoring science in America, and it's offensive as hell, and it's absolutely untrue.
just to add, I think we have to keep the big picture in mind. 90% plus of American parents get their kids vaccinated. So yes, there is growing concern. Yes, there's a fire hose of falsehoods to deal with. But I think the way we rebuild trust is by listening well, by communicating well, by identifying the right messages and messengers, by being clear about what we know and what we don't know. Science doesn't give certainty. Science gives humility. When you see people making, bold statements, they're not supported by transparently, objectively published scientific studies, especially if they're trying to sell you something, you really have to think twice. And on the one hand, I don't think we should lose sight of the fact that there's still a majority of the American public that does understand that vaccines are saving lives. And we also have to understand that in many ways, vaccines are victims of their own success. The fact that we don't have massive outbreaks of measles and meningitis and pneumonia and polio leads people to say, why should I bother to get vaccinated? So we do have to give that information on why this is important, highlight the personal stories on the harms, recall the past challenges that we've had with these deadly infections, and continue to respectfully answer people's questions while we also counter falsehoods that may be getting spread for various motives. Oops, you're on mute, Robert.
Next question is from Mike Stabe at the AP. Nandini, does IQVIA have vaccination trend data for other vaccines?
We do. We have vaccine trend data across the board for both childhood as well as adult vaccines. Yes.
So Mike may need to reach out.
Sounds good.
And a second question from Mike also regarding ACIP, and this is open to all the members of the panel. Can you speak more to the implications if the ACIP should one day recommend against using vaccines with aluminum adjuvants? Peter, do you want to start that one?
Yeah, I mean, I don't remember, why do we have aluminum adjuvants? Because the bacterial antigens themselves don't induce an immune response. So if you don't have an aluminum adjuvant, you're going to have another substitute. And to now explore alternative adjuvants would be probably a 5 to 7 year undertaking to show equivalency with because it's basically a new vaccine. I mean, this is, as a vaccine developer, the first thing you learn when working with the FDA is the vaccine is both the antigen and the adjuvant. So if you now have to substitute a different adjuvant, that's 5 to 7 years of research and development, tens of millions, hundreds of millions of dollars. Who pays for that? Well, the companies aren't going to do it. This is nothing. Remember, when they talk about separating the components of MMR into M and R, or taking out aluminum adjuvants and something else. Remember what they're really saying. This is a device. This is a device to remove vaccines out of the ecosystem and to jeopardize the American public. That's what all this is about. This is, again, just maha pseudoscience. The aluminum adjuvants are among the most tested, widely available, cheapest adjuvants out there. They're incredibly effective, incredibly safe, an extraordinary safety record. There is zero evidence to suggest that aluminum adjuvants are causing autism, all the other nonsense they're saying. So again, these are just more damaging statements coming out of Department of Health and Human Services.
You know, bottom line, a very rigorous study from Denmark of more than 1.2 million children found no association of these adjuvants, which have been used for decades, with an increase in any of the 50 chronic disorders assessed. So, you know, this is important because it's a concern, but I think people don't. It's important to be clear about what this is. This isn't aluminum foil being injected into us. This is a highly refined form of elemental aluminum, which is in a lot of our food. It's in a lot of our water. It's part of the environment. So I think it's always important to answer the concerns respectfully and factually, be clear about things that we don't know and need to study further, but also be clear that these are vaccines that are safe and effective. They've been used on billions of people, and they're one of the reasons we don't have massive outbreaks of hepatitis, that we should be able to actually eliminate cervical cancer from the world. So these are great accomplishments, and we need to address the threats to these accomplishments.
And maybe just two things I will add to what's been said. One is many of our vaccines use adjuvants. In fact, most of our vaccines that are not our live vaccines use these adjuvants. And to the extent that they are at risk, and especially the aluminum adjuvants, this will be a real challenge for many of the things that we use to protect ourselves. And then second, as Tom noted, aluminum is ubiquitous in many of the things that we eat and drink, and the dose of aluminum in these adjuvants is kind of a whiff of our daily intake. So this is intended to highlight and to scare, but as you unpack what exactly it is doing and how much of it is getting, and as Tom noted, the safety effects that have been studied heavily, including in millions of children, this should not be a safety issue.
Well, great. We've reached the end of our time. I want to thank all of our panelists for their presentations and for their answering our questions. I want to encourage all of you who've joined us to show your support for vaccination by joining the NFID Leading by Example initiative. Share your vaccination photos on social media using the hashtags #GetVaccinated, Fight Flu, Prevent Pneumo, Prevent RSV, and Stop the Spread. And be sure to tag NFID. This news briefing series is sponsored by NFID in collaboration with professional societies and patient advocacy partners, and unrestricted educational grants from AstraZeneca, Sanofi, and Seqirus. Note that NFID policies prohibit funders from controlling program content. A video of today's briefing, partner resources, and information about the series will be available on the NFID website at nfid.org/2025 Flu News. Thank you to our panelists, to our partners, and to the media for helping amplify these critical messages. Together, we can turn information into action, increasing vaccination rates and improving public health. By working together, we can reduce illness and save lives, not just this respiratory season, but for seasons to come. Thank you all once again.
Thank you.
Thank you.